Good afternoon, everybody. Welcome to Apollo Hospital's Facebook live session, your digital guide to good health. Today, we're going to be talking about the treatment of various vascular conditions, which include varicose veins, diabetic foot, aneurysms, ABS fistula for dialysis patients, etc. To talk about these conditions, we have with us Dr. Rajarajan Venkatesan, consultant vascular and endovascular surgeon at Apollo Hospital's Greaves Road, Chennai. Welcome to the session, Doctor.
Good evening.
So we have a lot of viewers who've been sending us some questions. So to start off with a basic question, so what are varicose veins, Doctor?
Varicose veins are abnormally dilated, tortuous, elongated veins occur in the normal vein if it is dilated. Normally, if it is 3 millimeter in diameter or 4 millimeter diameter, if it's an increase in diameter, also in the length, and it becomes tortuous, then it's called varicose veins. It occurs most commonly in the lower limbs. Sometimes it occurs in the upper limb as well. It can be due to long-standing workers, obese patients, pregnancy-related. Also occurs both men and women.
So what are the specific causes, Doctor, for varicose veins? Is it congenital or is it developed during one's life?
It can be primary or secondary. Primary, where it's this spontaneously it occurs in many individuals. Secondary, it can be due to any obstruction or kind of reflux or increased abdominal pressure. Also, it can cause mainly the more common in the ladies, those who are pregnant or after the postpartum, or it can be due to deep vein thrombosis, which occurs because of immobilization for longer duration, where there will be a deep vein can get blocked. Secondary to which there will be an increased dilatation of the veins in the lower limbs.
So what are the symptoms of varicose veins, Doctor?
It's basically because of the pooling of blood that occurs in the ankle level, especially in the lower leg, which is called gaiters area. All these toxic metabolites that is getting accumulated by the impure blood that gets deposited in the skin, which can cause skin discoloration or pigmentation. It can cause itching, which in turn leads to an ulcer formation, or it can cause bleeding. Varicose vein can cause limb swelling, or sometimes can cause even pain because of the heaviness of the leg, because of pooling of blood, which can cause pain in the legs and the feet, especially occurs in the late evenings. And those are long-standing workers like traffic police personnel, tea masters, nursing staff, and those who work for longer duration in the standing posture itself, they do have these kind of problems.
And so if somebody is standing for a very long time, this can happen.
Basically, the accumulation of the impure blood, pooling of the blood, that cause distension of the vein can cause pain, and because of the deposition into the skin level, it can cause black pigmentation, and also the toxic metabolites that can cause itching, in turn cause an ulcer formation, may not heal for longer duration, also associated with some kind of swelling, and this may drag for years together also.
So what can be done to prevent this, Doctor? So is there any physical activity, will that help? Or how can this be prevented, especially for people in that kind of professions?
See, they have to keep on checking of any small dilated veins. If they have, then they should start wearing some kind of compression stockings. If they start wearing the compression stocking, it can cause or prevent the accumulation of blood, and which in turn results in decrease the complication of the varicose vein. And if they have any dilated veins, they should go for investigating the severity of the problem by doing a Doppler scan, and how much reflex is there in the main valves, or if it's in only the outer veins or in the deeper veins. Accordingly, that can be prevented mainly by means of elastic stockings when they stand for longer duration, especially in obese patient or patient those who are long-standing workers.
So will physical activity help, doctor?
It temporarily can decrease because of pumping of the blood can drain the blood out of the legs. But once when you stop doing the exercise, that will ultimately increases the pooling of blood, because the main problem is in the veins where the valves. It has got one-way entry. It pumps the blood from below upwards to the heart. If the valves doesn't work, the blood can come from above downwards and gets accumulated down. So we need to check it which valve is problematic, whether it's in the inner side of the thigh or the outer side of the knee or level where there are two main valves. Apart from that, there are connecting veins which has got valves. If they are problematic, that can be dealt by different means of treatment. But all these problems related to varicose vein can be simply just managed with the stockings when they stand for a long time. And especially during the bedtime, they can just remove the stockings.
So what are the treatment options available for patients suffering from varicose veins, doctor?
This mainly for the primary varicose vein. We need to do the Doppler scan and assess the severity of the reflex, which vein is affected, the main valve, how many main valves are affected, and any perforator or connecting vein, is there any reflex in that, and assess the deeper veins. If the deeper veins are normal in the Doppler scan, then we can consider for various methods of treatment modalities available. One is the open procedure or laser procedure is available. Also, some kind of injection sclerotherapy depends on the which level or which vein is affected, or whether it is above the knee level or below the knee, and accordingly the treatment varies.
Doctor, like one viewer wants to know about spider veins. So what are spider veins, doctor, and can spider veins lead to varicose veins?
There are different classes of veins or stages of veins. When it started as a small veins with less than 1 millimeter or 1 to 2 millimeter, they are called spider veins or reticular veins, thread veins. Initially started from around the ankle, and those are different stages. Next goes to the dilated veins along the course of the veins, where the same vein can increase in diameter and length and also becomes tortuous. They are varicose veins, and these spider veins can even cause bleeding or can cause swelling at the ankle level, which can be treated with some kind of injection sclerotherapy, where a chemical sclerosing agent is injected into the vein, can cause shrinking of this vein, prevent accumulation of the blood into these veins. And different classes can even go into the skin color changes, ulcer, which is healed previous ulcers, and lastly, which is class 6. So class 0 to class 6. The class 6 is the active ulcer, which is not healed for longer duration. So there are different classes of venous disease there.
Doctor, one of the viewers wants to know if her diet will affect varicose veins.
Diet does not have any role, especially only thing, if they are obese, then they should not put on weight, or they have to reduce the weight, but it doesn't have any direct impact on the veins.
Okay, no, thanks for that, doctor. And if, let's say, the treatment is delayed, or if one chooses not to, if they're not diagnosed varicose veins properly, so what sort of complications can one expect?
Especially the pooling of blood can cause stagnation, which result in clot formation. It's called thrombosis of the superficial veins, outer veins, which can extend into the deep veins or deep vein thrombosis. It's called DVT in 10 to 20% of individuals. So stagnation of blood causes clot formation, thrombosis. Number 2, it can cause distension of the vein, resulting in bleeding. And as I told you, can cause skin color discoloration, swelling, itching, ulcer formation.
Does it also lead to internal bleeding, doctor?
Yeah, it can even. If small trauma can because if there is a dilated vein, the walls are very thinned out. It can cause a rupture of the vein inside the leg itself.
Okay. So what is a diabetic foot ulcer, doctor?
Yeah, as we all know that India is the capital of diabetes, and it is very common, and it is going to be the leading cause of worldwide. This is the fourth leading cause of death due to diabetes, and by 2035, India is going to be the second, or even sometimes first after the China. So, one in every 10 seconds, the diabetic patient are dying because of diabetes-related problem. 1 in 30 seconds, some part of the body or a limb can get amputated because of diabetes. So, diabetic foot infection begins with an ulcer. It can, because even for a trivial injury, it can get initiated, and increases the risk of amputation, because most of the diabetic patient have neuropathy, which is can affect the sensory system or a motor system, or it can cause decreased blood supply, which is ischemia, or a combination. So majority of the diabetic patient, they do have neuropathy, 60%, and 40% they have both neuroischemic combination. 10% have decreased circulation. All this can cause a small ulcer. Suppose if a patient has got a sensory neuropathy, there will be loss of pain sensation. That loss of pain, they will come, which the small ulcer can go unnoticed. Because of autonomic neuropathy, there won't be any dryness of the skin, can cause cracks, fissures, which can initiate entry of the bacterial organism can cause infection, and also loss of motor function can cause abnormal pressure points in the foot, which can initiate ulcer. So we need to identify those patients, those who are increased risk of forming an ulcer. They are called foot at risk in diabetes.
So what are these risk factors, doctor? Can you just elaborate on them?
As I told, all diabetes should be examined for the presence of neuropathy and also ischemia, decreased blood circulation, annual checkup of the peripheral pulses. How is the pulse status? How is the sensation? How is the motor function of the feet? Has to be checked once in a year, and they have to strictly on sugar control. If they are smokers, they should stop smoking. If their blood pressure has to be controlled, any cholesterol has to be controlled, and they should be on regular follow-up of this to prevent any form of foot ulcers. Those patients, those who are diabetes, at least 15% of them, they develop foot ulcers over lifetime. And definitely, the risk of amputation is 25% in all diabetic patients.
So if a person who's suffering from a foot ulcer, how should it be treated, doctor? How can he go and approach for treatment?
Yeah. So we need to assess for the vascularity, blood circulation. How is the pulse? That is the foremost important factor that is deciding for amputation. So if the blood circulation is fine, then the risk of salvaging or healing is very good. So suppose if the pulse is not felt, we need to check the pressure in the foot and the toes. Then comes the Doppler examination. Then comes the sensory system and motor system assessment. So accordingly, we do a Doppler scan to look for if the pulse is not felt, to look for the level of blockage anywhere in the system. Start from the main trunk of the blood vessel and goes to the right side or left side, whichever leg is affected. And then, if it's necessary, we may have to do an angiogram. That can be a CT angiogram or a MR angiogram. Accordingly, the treatment goes on. If there is a block, if there is a stenosis or narrowing of the blood vessel, or if there is a block, there are different treatment modalities. One is the balloon angioplasty. Number two is the open surgeries available.
So a person should approach his or her diabetologist first, or should he come to a endovascular surgeon?
See, all these patients are referred, mostly they go to the diabetologist, which will pick it up to the diabetologist and then refer to us for the vascular assessment. Any blood vessel problem or blood vessel is not good, we will then treat those patients, and then along with the diabetologist, we keep them the blood sugar under control, and we treat according to the level of blockage. Where a small keyholes procedure can heal the ulcer. If there is any block in the blood vessel in the thigh, we do a puncture in the blood vessel in the groin and then put a balloon, open the stenosis or the blockage. Then the circulation is reestablished, the perfusion goes, then the ulcer heals. The first and foremost is to heal the ulcer and relief of pain automatically there, and simultaneously controlling the blood sugar. If there is any infection, we need to give an antibiotics along with that.
Thanks, doctor. So moving on to the next section. So what is an aneurysm, doctor?
Aneurysm is abnormal dilatation of the blood vessel, which can occur in an artery, most commonly also in the vein. Artery is the blood vessel which carries the pure blood. Vein is the blood vessel which carries impure blood. So aneurysm is anything abnormally dilated. If it is more than 1.5 times, it's called an aneurysm. Suppose if the diameter is 1 centimeter for that vessel, if it is more than 1.5 centimeter, then it is called an aneurysm.
So what causes these kind of aneurysms, doctor?
Most commonly, the degeneration of the blood vessel, age-related, or atherosclerosis because of increased cholesterol or deposition of the fat, which can weaken the vessel wall, can cause dilatation of the blood vessel, which can get aggravated by increased BP. Like if the patient is hypertensive, the pressure which is given into the blood wall, weakened wall, which can cause increase in diameter of the vessel.
So in terms of symptoms,
it can be due to a trauma or like any injury which has been not noticed, or a trivial injury to the abdominal, or it can occur anywhere in the blood, any blood vessels of the body. It can occur in the neck, which is called carotid aneurysm. It can occur in the upper limbs, or brachial artery aneurysm, subclavian aneurysm, or some kind of pressure effect can cause an aneurysm.
So what are the symptoms for these kind of aneurysms? So what does the patient feel? Is it painful?
Most commonly, more than 95%, it occurs in the abdominal main vessel, which is called abdominal aorta, which is below the renal arteries. So most of the time, because they may not have any symptoms, some they come following and incidentally they detected following investigation for any other problem in the abdomen. They do an ultrasound, they find out suddenly there is a dilatation of the aorta. Depends on the diameter, the treatment goes on. And symptoms depends on if there is any compression symptoms. Suppose if it compresses the intestine, if it compresses the kidney blood ureter, or if it compresses symptoms, or if it is because of there will be intraluminal clot will be there in the aneurysm. If it throws into the fragment, the clot can get fragmented and come into the lower limbs, can cause acute limb attacks, where there is increased risk of limb loss, or where is a deadly complication due to aneurysm can cause even rupture if it is increases in size, especially in smokers and also hypertensives, or following a small trivial trauma where it was in the presence of aneurysm which is not picked up. Suddenly they come with sudden pain, sudden collapse, a sudden low hypertension, low BP, with abdominal pain can come.
So what are the treatment options available, doctor, for an aneurysm?
It depends on the diameter of the aneurysm. We classify the aneurysm into small aneurysm and large aneurysm. Anything less than 4 centimeter in diameter, which is measured by an ultrasound or a CT scan. A CT scan gives an accurate diameter measurement of the aneurysm. Anything less than 4 centimeter, the risk of rupture is less. So we need to just observe. Every once in 2 years, need to do an ultrasound to monitor the size or the growth of aneurysm. And it varies 4 to 5 centimeter. We need to call them every 6 monthly and measure the size. Anything more than 5 or 4, 5.5, which needs to be treated because the risk of rupture is more. Suppose if it is 6 centimeter or 7 centimeter, the risk of rupture per year is up to 20%. If the size of the aneurysm is 7 to 8 centimeter, the risk of rupture is up to 40% per year. So once when it ruptures, the risk of life is very high. 50% of them, or more than 50%, 65%, they don't even reach the hospital if it ruptures. They die when they come to the hospital. Once when they reach the hospital also, the risk of mortality is very high, up to 80%. So only 20% only we'll try to save them, even by intervention. That's why before it ruptures, we have to treat those aneurysm or keep measuring, keep in the follow-up to measure the size of the aneurysm. If it is reaching the optimal level, 5.5 centimeter is the cutoff. But more than 5.5 centimeter, it needs to be treated. There are different ways of treatment available. The gold standard is open procedure, and we open the tummy in the central part of the body, the abdomen, and repair with the artificial graft, which is called endoaneurysmography. And the next is, because of now advanced technology is available, we call it as endovascular aneurysm repair, EVAR. With a small puncture or a small opening in the groin, a device is inserted into the aneurysm, and the blood flow is the aneurysm is excluded through the stent graft. So, where the patient can get discharged in 4 to 5 days. But in open aneurysm, where the patient has to stay for 10 days minimum to 2 weeks, and depends on the risk category. Most of these patients, they are older age, more than 70 years or 60 years, associated with diabetes, hypertension, cardiac heart disease, smokers, or cholesterol problem. They do have other multiple comorbid problems. So where we have to choose this patient, which patient is suitable for open procedure, and which patient is suitable for the endovascular procedure. So according to the high risk category, where endovascular can be opted, if the patient is a good risk, who's 50 years old, where open procedure can be opted.
So these treatment procedures, doctor, like how long does one expect to stay in hospital, and how fast can one get back to his routine life?
See, minimum 2 weeks in open procedures, because of complications can develop because of after the surgery, especially if it is an elective procedure. They have to be evaluated by the cardiologist, lung pulmonologist, and also the anesthetist. We all sit together, and the critical care people, depends on the risk, how many days the days of hospitalization varies. So in an open procedure, in an elective situation where they can just, if you prepare the patient well, they can get discharged in 10 days time. If it's a high risk patient, sometimes it may get prolonged because of the chest respiratory problem. They may be in the ICU or ventilator for some duration. They may develop some kind of a kidney problem, which needs to be addressed, which may take some 2 weeks time, or more than 2 weeks. And if it is an endovascular, that too, whether it is done for an electively or for emergency. So elective, again, they can get discharged. There's no need of opening the tummy. They just have one small puncture in the left groin and small opening in the right groin, where the device is inserted through the blood vessel and inserted. They can get discharged in 4 or 5 days time. And if they come in emergency rupture, we can't predict. All these patients, they may receive massive blood transfusion. They may have to stay for longer duration in the ICU, a long hospital stay. They may have get some infection in the chest, or they may need to undergo dialysis because of kidney, because of low BP. There may be kidney issues or some kind of limb problems. So we can't predict how many, minimum 3 weeks, and depends on how early they come.
Okay, you were talking about a lot of complications of aneurysms and these conditions. Given these complications, what sort of advice would you give to the patients to pick this up earlier so that it doesn't lead to a hemorrhage or they don't come and present at the hospital at a later stage where it might be difficult to treat?
Or a routine examination in the master health checkup ultrasound to look for the diameter of the vessel. Normally, the diameter is 1.5 to 2 centimeter. So, if the diameter is normal all along the abdominal aorta, then this don't have to worry of this. Or if there is any slight increase in diameter, then they should keep following this scan every once in a year, depends on the size, and keep following the vascular surgeon.
So is it a part of the regular health checks, doctor, or do they need to go in for any advanced health check?
So especially in older individuals or elderly individuals, and those who are having hypertension or hypercholesterols, hypertriglycerides increase, that is lipids also. Then when they go for the checkup, they can even check because they are all because it occurs more in the elderly individuals.
Thanks, doctor. So moving on to the next question, doctor. This is about dialysis and dialysis patients. So what is a fistula, doctor, and how is it used in dialysis?
See, chronic kidney disease is again the very important disease to be managed and very common in diabetes patients as well. And day by day it is increasing. So the need for hemodialysis or dialysis in these patients are very important. And any patient who has got a rising creatinine or breathing difficulty, or which we call it as uremic symptom, and they'll be on regular follow-up with the nephrologist. The nephrologist, they assess this patient when to undergo dialysis. Suppose it depends on the symptoms or rising creatinine or rising potassium and or any fluid load volume, they're not able to breathing difficulty. So they send the patient for the vascular access, which is nothing but creating a AV fistula, which is a lifeline for this chronic kidney disease patient. We create a fistula, that is a connection between the artery and the vein in the upper limb, especially in the wrist level. That is the first choice. Or in the non-dominant hand, and the second choice is the right dominant hand, and also third choice is the elbow, fourth choice is the right elbow, and depends on the presence of veins, presence of a good vein, presence of a good artery. We create a fistula, which is called arteriovenous fistula, and slowly it gets matured in 6 weeks' time. Once the fistula gets matured, then it will be fit for puncturing and drawing the blood, putting it into the machine for purifying the blood and reset it to the vein. So the idea is the decision will be taken by the nephrologist when to undergo AV fistula, and they'll be sent to the vascular surgeon for creation of that. AV fistula is otherwise called AV access, nothing but drawing of blood pure for purification, putting into the machine and reinserting into the body. So these AV fistulas are actually, as I told you, it's a lifeline. Depends on the diameter, quality of the vein, quality of the artery. The longevity of this fistula varies. Some they have 6 months duration, and some they fail. Even if it's a small veins, very difficult to mature or very even function. So we need to do a scan to assess the status of the blood vessel, and then subject them for AV fistula surgeries.
So is this surgery a very long process, doctor, or is it like very painful? Or
it is usually done as a daycare procedure. It takes half an hour to 1 hour time. If it is a simple fistula, those who have a good quality vein, good diameter, more than 3 millimeter vein with a good artery, they do well. And morning they come, and evening they can go. Preferably, they undergo the procedure after the day of dialysis.
so are there any complications for this procedure, doctor?
See,
for installation of AV fistulas?
all these patients, those who are on catheters, depends on the catheter. They can't keep the catheter for more than 2-3 weeks time because they come in emergency of breathing difficulty. They found out there is a kidney rising creatinine. There is a kidney disease. So they have to put a neckline for dialysis. They remove the waste products into the purification. And if the catheter duration is longer, the risk of infection is more, or sepsis. The risk of blockage of the catheter in the neck is very high. So as quickly as possible, they have to convert this temporary catheter into a permanent AV access by means of fistula. So they do a fistula first. Those who are not having a very symptoms, those who are rising creatinine, some from 3-4 creatinine, if they feel, the nephrologist feel okay, we'll let him undergo a fistula procedure. In the event if he requires a dialysis in future, can undergo or dialysis. So we normally, those patients, we call a fistula first mission, where any patient does a rising creatinine, create a fistula preemptively in the future if he needs a dialysis. Those patients, the risk of complication is less. Those who are on catheter, the risk of infection may be high, or there may be some bleeding can happen, or some kind of wound complication can happen. That can be tackled, according to the situation.
There's a question from a dialysis patient. So, how long can one survive on dialysis?
It is a very difficult question to answer. It depends on various individuals. Some, they live even for 15 years or 20 years on dialysis. And putting that individual into consideration, like, need to have access for the dialysis, or a good functioning fistula has to be there. Some, they may not have a good access, or they may have multiple access failures. They may not be able to sustain. So it varies from individuals to individual. So it may be minimum. We can't even say how long they live, or the maximum. I've seen patients up to 15 years or more than that, but not everyone. Some, as quickly as possible. The best alternative is the undergoing a transplant.
So, could you explain a little bit more about that? Is that an alternative to for dialysis?
That's the best option for any kidney failure patients, because kidney fails means we need to put a kidney, but the availability of organ, the availability of the donor, the cost of the procedure, the availability of the center, those who do the kidney transplants. So all these things matter for the next. That is the next alternative is the dialysis. If they have a good fistula, matured, functioning, they can pull through for many years. But as soon as they get a donor, or for the that the kidney transplant will be the best option.
Doctor, you were mentioning about vascular trauma. So, could you explain a little bit more about that and what sort of injuries can take place?
See, road traffic accidents are common in youngsters. It can cause fractures, limb trauma, or abdominal trauma, or head injuries, especially the extremity injuries where it can fracture a bone, also the soft tissue, also the blood vessel. This is the most common. It can cause blood vessel rupture, or blockage of the blood, sudden blockage of the blood vessel, which can cause decreased circulation to the foot and can end up in amputation. It can be due to a blunt injury, or open injuries, or sometimes also stab injuries, which can directly puncture the vessels in the neck, can even cause bleeding or clotting of the blood vessel. So all these individuals, they have to be transferred to a center where there is a vascular facilities available, which is called a golden hour. Definitely between 4 and 6 hours. So if they get transferred to within the golden period, definitely they can get saved of their limbs, or can stop bleeding. The bleeding is also cause, because of blood vessel injury, it can cause bleeding, and in increase the risk of life. So we need to be transferred to a center where there is vascular facilities available. Mainly the limb trauma, fracture associated with vascular injury has to be operated within 4 to 6 hours to prevent amputations.
So does this involve a reconstruction of the veins and the arteries?
Yeah, it can cause even arterial injury or venous injury, which needs to be repaired. Depends on the length of injury. If it is a small injury of 1 centimeter, we can just do a direct end-to-end joining. Or if it is a long blood vessel block or it is shattered limb, where we may have to do a long bypass, where we take vein from the opposite limb and do a bypass from the normal limb to the normal blood vessel to the normal blood vessel.
Thanks for that, Doctor. So with that question, we have come to the end of this session. So as an ending note, is there any specific advice you would like to give to the viewers or any message you would like to say?
So most of these problems are preventable. Like as I said, varicose vein, which can be, we can prevent complications by wearing simple stockings. And diabetic foot ulcer, which can be prevented by self-examination or looking for any cracks, fissures in the feet, addressing it early. And every annual checkup of blood vessel or pulses in all diabetes is mandatory to prevent major vascular or major foot loss or major amputations. And those who are going on for a martial checkup for preventing or looking for any dilatation of the abnormal dilatation of the blood vessel in an ultrasound, which can easily be picked up. And fistula, all chronic kidney disease patient, those who are on regular follow-up with the nephrologist, should monitor the creatinine level, potassium level, and as soon as the nephrologist decide for the fistula, they should undergo the fistula to prevent any acute emergency or what we call it crash landers for the dialysis, where the neck can be just neck veins can be not be used for acute situation. So if you create a fistula as a preemptive measure, where we can undergo dialysis as and when it is required in the near future.
Thank you so much, Doctor.
Thank you.
Thanks for joining us today. Thanks to all the viewers who've been tuning into our Facebook live session. Until we meet in the next time, thank you and goodbye.